Good evening. My name is Mary Vias. I'm the president of PSC Partners Canada, and together with Audra Fleming, executive director of PSC Partners Seeking a Cure, we welcome you to the second of the PSC Partners 2025 webinar series, Fatigue in PSC, Leveraging Scientific Discovery to Improve Well-Being. Today, we are honored to welcome Dr. Mark Swain, a professor of medicine and the head of the Division of Gastroenterology and Hepatology at the University of Calgary, Alberta, Canada. He currently holds the Cal Wenzel Family Foundation Chair in Hepatology. Dr. Swain is a clinician scientist with a basic science research interests focused on how liver diseases cause symptoms such as fatigue. Just this month, I had the pleasure of attending the Canadian Liver Meeting in Quebec, where Dr. Swain was honored with the CLF-CLM Gold Medal. At the ceremony and award lecture, Dr. Swain shared his career journey and his deep interest in discovering what happens in the brain when one lives with liver disease. This has truly been a lifelong focus. Dr. Swain is also an active contributor to many of our PSC Partners initiatives. To name a few, he is on the Community Advisory Board for the PSC Partners Symptom Assessment Project. He's a participant of the PSC Partners International Collaborative Research Network, the ICRN, and he was one of the experts at last year's patient conference. Before we get started, since Dr. Swain and I are both coming to you from Canada, and as an act of reconciliation with the Indigenous peoples of Canada, I would like to offer a land acknowledgement and recognize that we live, work, and learn on the traditional territory of many nations. The University of Calgary is in the heart of southern Alberta, home of the traditional territories of the peoples of Treaty 7, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta. PSC Partners Canada operates out of the Centre for Social Innovation in Toronto, which is covered by treaties signed with multiple Indigenous bands. Toronto is the home of traditional territories of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. On this land and in these places, we strive to learn together, walk together, and grow together. Over to you, Audra.
Welcome everyone to our Fatigue and PSC webinar with Dr. Mark Swain. We're absolutely thrilled to have you joining us tonight and for the important discussion on fatigue and PSC. Fatigue is one of the most common and debilitating symptoms experienced by those living with PSC, yet it remains poorly understood and often overlooked. So we're thrilled to have Dr. Swain here to give us some insight and go through and explain a little bit more on the correlation. Next slide. So just a few logistics for tonight. Before we start the program, please mute your mic and turn off your video. And as you listen to Dr. Swain's presentation, please submit questions in the Q&A box located on the Zoom control bar, usually at the bottom of your screen. We welcome your questions, and we ask that your questions are to be more broad than very specific. Please note this forum that we ask for your questions to be that, as we don't want to address a very specific medically related question to your situation. We offer closed captioning, which can be found in the lower right corner of most screens. If you are on the phone or tablet, look for the show captions icon. You can also locate translations through this button, then click subtitles, and finally click on the auto translate and choose your language. Lastly, please fill out the post-webinar survey at the end of the webinar. We greatly appreciate your feedback and suggestions, and we'll provide a QR code at the end of the webinar on the screen, as well as a link in the post-event email that you will receive after this webinar. Next slide. Now it's my pleasure to introduce to you Dr. Mark Swain, a leading expert in liver diseases. His research has significantly advanced our understanding of how liver-related fatigue develops and how it can impact daily life. During this webinar, Dr. Swain will share insights into the biological mechanisms behind fatigue, potential management strategies, and current research efforts. We will also have time for Q&A, so be sure to submit your questions throughout the session. I'll turn it over to you now, Dr. Swain.
Thank you so much. I'm just going to load up my slides. Okay. So hi, everyone, and thanks very much for joining. I'm very pleased to be talking to you tonight about a topic that's quite dear to my heart.
I'm so sorry, Dr. Swain. I apologize for interrupting. We're seeing the PowerPoint screen. We're not seeing them full screen. If you'd like to put in a presentation.
Hang on here. Let me go up to the top. How's that?
That's much better. Thank you.
Excellent. Good. Okay. Sorry about that, everyone. So I'm going to talk to you tonight about fatigue and PSC, and I'm going to talk about some of the I think the scientific information that's been accumulating about fatigue and how it comes to be in the setting of something like chronic liver disease, and then I'm going to talk about some of the approaches that that one might take to try to improve fatigue if they're experiencing it in PSC. Before I get started, I just want to sort of talk about some overlapping issues and concepts that it's important that we all consider as I sort of go through this, because there isn't a lot known specifically about PSC and fatigue as other than its impact on people's daily life, which I'll go through in quite a bit of detail. However, the basic mechanisms that drive fatigue and PSC are very poorly understood, and so I think it's important to recognize that there are other liver diseases where information is more available, and one of those diseases is a liver disease called primary biliary cholangitis, or PBC, and there's been a lot of research done in that area. Partly because it's a specific disease. It's only a liver disease, and so with PSC, there's an overlap with inflammatory bowel disease in many people, but also there's a specific diagnostic test, and so it's quite readily diagnosed. Both of these diseases have an impairment of bile flow. So in PSC, their impairment can be both intrahepatic, so the ducts, the tubes that drain bile out of the liver itself, but also the tubes that are outside the liver. Whereas in PBC, it only affects the smallest little tubes in the liver. But the overall impact is that bile does not flow out properly. So we can learn a lot, I think, about PSC and its effect on the brains by also looking at the effect of PBC on the brain, where there's so much more information. It's also important to recognize that fatigue in people living with PSC has to be taken in the context of those that have inflammatory bowel disease, or IBD, and those that don't. And so I'll talk quite a bit about that as well. There's also a lot of challenges that are associated with the fact that there's no PSC specific health-related quality of life measuring instrument, whereas PBC, an instrument has been developed for many years, and so that allows a very specific understanding of how the disease impacts people's quality of life that refers directly to PBC. And so there's a lot of efforts going on to make a PSC specific quality of life measure, but it's not available yet. And also I'm going to talk about the role of itch and sleep disturbance in PSC related fatigue, because they are interrelated and important. So first of all, fatigue and PSC, how big is the problem? So if you look back in the earlier studies, so in the early 2000s and even as late as 2012, there was a number of studies that suggest that fatigue was not a significant issue in PSC patients, and which is fascinating, of course, because I think that we recognize that that's incorrect. Actually, these early studies suggest that fatigue in PSC patients was similar to the fatigue levels that are found in the general population. I think that's also slowed down some of the research momentum that would have gone into looking at fatigue in PSC. However, there's been a number of studies, and I think many of you are probably familiar with the online patient registry from PSC Partners, and they have explored the symptoms that patients experience. And um, in this questionnaire, there was 811 people that completed the questionnaire. 75% were from the United States, and 67%, so 2/3, had inflammatory bowel disease and PSC. And you'll see this number comes up again and again, which is pretty much what most of these studies find, that about 2/3 of the people will have both IBD and PSC, and 50% of the people were taking URSO or UDCA. What this registry found was that fatigue was the most common symptom experienced by PSC patients, and that 75%, so 3/4 of PSC patients, were fatigued. There was a nice study that was presented at the liver meeting in 2024 by Donna Evan, and this is the sort of the preliminary work that has gone into starting to develop the quality of life questionnaire, but this was specifically about fatigue and PSC. And what they did was they did specific interviews of people with PSC, and they took out concepts which they call elicitation interviews, which are basically to pull out the concepts around fatigue or symptoms in individuals that have PSC. Again, about 2/3 of the people had IBD, and then they did 17 in-depth interviews. And of those 17 individuals that were interviewed, 12 reported fatigue as a prominent or a very significant issue. And so when they graded it to try to decide that, there was a scale of 3 to 13. And so 13 being the most a prominent issue, whereas 3 is least. And the average for these individuals was 10. So it was pretty significant. And 50% of the people said that they had fatigue all of the time. And fatigue was commonly associated with brain fog, which is often associated with fatigue in many chronic illnesses. And it's in the scientific way of saying it is really cognition or cognitive changes is really what a scientist would call brain fog. There was also this great study from 2020 that was done. It was our Voices survey, so 819 patients from the PSC Partners, and what they did was they asked. It was all about the symptom impact in PSC, and they on the left-hand side of the screen, it's so. What the question was at its worst, how much did a symptom, and the symptoms are all listed there, impact a person's life, how they felt and how they function. And you can see the very top of the list is fatigue, and it was really about 65% of people. In the red part, it was a major impact, and a relatively smaller number, it was a minor impact. And then on the right-hand side, the question was similar, but it was really over the past 6 months, how has a symptom impacted how an individual felt or functioned? And again, fatigue is the top, and you can see about 30 to 35% of people, it had a major impact on how they felt and functioned over that whole 6-month period. And so obviously fatigue is a major issue in people with PSC. There was a study that came out of Denmark. Sorry, not Denmark. Out of Holland, and what they did was they actually used a mobile app, and they used what's called a visual analog scale questionnaire. And these are very commonly used for symptoms, and basically the visual analog scale scores people from 0 to 10, and so 10 out of 10 is as bad as it gets, and 0 out of 10 is none. and they would send notifications out to individuals who had this app, and then the questionnaires were available for them to answer for a 4-hour period, and then they disappeared. And basically, the question that they were asked about fatigue was, how severe is your fatigue at this moment? And again, there was 137 patients, and 65% of them, so 2/3, had inflammatory bowel disease as well as PSC. The time of day and season were recorded over 3-month periods. And in this study, 71% of the people were fatigued, and 20%, so 1 in 5, had a VAS score that was greater than 7 out of 10, which is actually a boundary or a number used to define severe fatigue. And interestingly, fatigue correlated with disease duration in this study, which it doesn't necessarily in all the studies. It was worse in the afternoon around 4 p.m. And it didn't seem to correlate with inflammatory bowel disease status. Now, this same study also asked the question, how bad is your itch at this moment, and also with sent out through the mobile app. And what they found was that itch was reported in about 38% of PSC patients, which is quite similar to the PSC partners one. And you can see that the VAS score here, if it goes from 0 to 10, the scores are somewhat lower, and more people had no itch than had no fatigue. But again, if you look at on the right-hand side, the peak moment of pruritus was again later in the day. So an overlap of the peak moment of pruritus with when one is trying to sleep, actually. And so there is this interrelationship between itch, sleep disturbance, and fatigue, which is an integral part of PSC. And in fact, it's also an integral part of PBC because itch is a manifestation of poor bile flow, and it really is when bile is not flowing properly, itch can occur in any disease that's causing that. So if you have a stone blocking your bile flow, itch is a common symptom. PBC, which blocks the small bile tubes, people get itching, and it's commonly reported. But what you can see if you look along the top, there's mild pruritus severity, moderate pruritus severity, and severe pruritus severity. And if you look in the bottom, maybe just look at the bottom two. So there's something called the 5D itch scale, and there's one part of that that's about how it impacts sleep, and you can see the numbers themselves don't really matter, but you can see these numbers go higher, and this number is out of 5, and you can see that once you get to severe pruritus, that there's a huge impact of pruritus on sleep. And if any of you are itchy, I'm sure that it's not news that itch as it gets worse is going to affect your sleep, especially if it's coming at nighttime. And this is the PBC 40. This is the specific scale for PBC. And there's a question about itch disturbance of sleep, and you can see the same thing. The numbers go higher. So in PBC, just like in PSC, pruritus and sleep disturbance go hand in hand. So what's the contribution of inflammatory bowel disease to PSC-related fatigue? So this was a very nice systematic review. A meta-analysis actually came out of Calgary, but it was published quite recently in 2022. And what this did was it looked at a number of different studies and databases, and they basically synthesized or put together all of that information. And what they found was the estimated prevalence of fatigue and IBD, so this is inflammatory bowel disease without PSC, was almost 50%, so 47%. Higher in Crohn's disease than ulcerative colitis. And if someone had active disease, it was as high as 72%, so active inflammatory bowel disease. But in remission, it still was 47%. So what this tells you is that there's a big overlay between the fatigue that you see in people that have PSC and the fatigue that people have with inflammatory bowel disease, which has to be taken into consideration. And so there was actually a nice study done by David Jones and Jessica Dyson in the UK when they studied 3 groups. One group had PSC, one group had PSC and IBD, and 78% were male. So you can see, again, almost 2/3 had IBD. And then they used primary biliary cholangitis, or PBC, as controls, and then just people who lived in the community who didn't have IBD or PBC. And they used a scale called the fatigue impact scale. It doesn't matter, just a way of measuring fatigue with a total score of 160. The higher the score, the more fatigue. And what they found was the fatigue was higher in PSC patients than community controls, which isn't surprising. And they found that in this study, 35% of the PSC patients met the criteria for being fatigued based on this FIS score. And the fatigue was more severe and more frequent in patients that had both IBD and PSC. There was no association with serum liver biochemistry. So if their alkaline phosphatase was higher, it didn't seem to associate with fatigue. And the fatigue was similar in PSC with IBD compared to IBD or inflammatory bowel disease alone. And this is the data. So if you look on the left-hand side, so at panel A, this is fatigue severity. And you can see the normals are here. The cutoffs are a dotted line that goes across. And you can see that both PSC and PBC had a higher scores on average than the normal controls, but they were not different. So the fatigue that was being experienced as with regards to severity were similar. And if you looked at the frequency of significant fatigue, it was also similar. It was way higher in the PSC and PBC than the normal controls, but it didn't differ between those two groups. And if you looked at individuals that had PSC and IBD, or PSC and no IBD, or IBD alone, which is in the right hand. So look on the left hand panels. This is fatigue severity. You can see that this fatigue severity is for PSC with no IBD, PSC with IBD, and IBD are all greater than on average than controls, but they're not different from each other. In addition, that if you look at the frequency of significant fatigue, so this is the people that are above that dotted line, you can see that although it's not significant, there seems to be a trend where when you have PSC with no IBD, it has lower fatigue than PSC with IBD, and IBD in this study even had the highest fatigue. So there's this interrelationship that's happening all the time in PSC, especially if people have IBD. So I think it's quite clear from this data that fatigue has a broad impact on a person's quality of life in PSC, but does it impact their length of life? Well, there's no data from PSC, but can we look elsewhere to see if fatigue impacts the length of life? Well, it's been known for many years that if you ask a simple question about fatigue in an elderly population, it correlates directly with their overall mortality. If they're fatigued and answer it as yes, they have a higher mortality than people that answer it as no. But this study was the first to actually go into a population that was just a general population. And what they found was that fatigue was actually associated with excess mortality in the general population. And this was for a study from the UK. Also, there's been a number of studies that have looked in PBC patients. Again, this is PBC, not PSC, because again, there's more data that we can get from PBC, but I think it informs about people that have PSC, although this is going to have to be looked at more closely in the PSC population. That PBC patients who initially present with fatigue, they also show an increased overall mortality compared to those that present initially without fatigue. And this just shows this is a percent surviving. It's a standard kind of survival curve that you'll often see in scientific presentations. The bottom line is that if this line is lower and significantly lower than that line, that these people survive less well or have a shorter life. This is over a span of 16 years. This is another study that looked at the percentage of patients that are surviving. And you can see that the people that have a higher fatigue score with PBC survive shorter than the people that have a lower fatigue score. And then there was another study where they actually looked at they called the individuals with PBC as either high fatigue or low fatigue, and they compared them to controls. And you can see there's a gradation here. This is again transplant-free survival, so it's essentially surviving with your liver intact. The controls are up here over a follow-up of 110 months, but if you have low fatigue, you're still below controls. If you have high fatigue, you're significantly lower than controls. So fatigue seems to have an impact in survival, and people do not understand why that is. So I'm going to turn now to talk about fatigue itself and some of the concepts around fatigue, because it's important to understand where fatigue comes from, because that allows you then to develop strategies on how to deal with it or cope with it better. So when I think about fatigue, I think about two types of fatigue. I think of central fatigue. So this is fatigue that essentially comes out of the brain, and peripheral fatigue, which is what this athlete running up the hill showed. And first of all, when you look at peripheral fatigue, this is really fatigue that is generated by problems with the muscles or problems with the nerves that feed into those muscles, or the junction where the nerve signals that muscle to do what it's supposed to do. So if you have muscle issues, so muscle wasting would be an example, or if you have a nerve problem, or you have something like myasthenia gravis where this junction is affected, people can develop peripheral fatigue, but it's classically associated with weakness, which is not really a big typically an issue with people with liver disease until they start to get muscle wasting. It's usually fatigue, and they usually don't have specifically muscle weakness. So what's central fatigue? Well, central fatigue, it arises from changes in neurotransmission. So this is how the nerves are functioning or talking in the brain, within the brain. And importantly, people often say, well, I feel physically fatigued. But central fatigue can be felt as both physical and mental fatigue. And this is a critical component to understand that both of these ways of perceiving fatigue are part of central fatigue. And central fatigue really relates to a balance in the nerves in our brain that regulate motivation compared to the ones that regulate reward. And the fancy term is cost benefit trade-offs, which is really every action that we do that expends effort, we really our brains are processing what is the cost to do that, what's the cost in energy and risk and all the other things compared to the potential benefit that we might get from it. So the cost is and the versus the benefit is how we develop motivation to do things. That's all subconscious. I mean, obviously you can do it consciously too, but this occurs all the time with every action that we do as human beings. And so when you look at central fatigue, you can almost the symptoms are classically assessed with questionnaires, and the questionnaires are often considered to be subjective, which is part of the issue, because subjective things are often not viewed the same by physicians or scientists as things that are objective. And objective means it's measurable by doing something, whereas subjective means it's the person telling you or doing a questionnaire describing how they're feeling. So when you look at, I think this is a very nice paper where they kind of break these down into subjective symptoms on the left-hand side and objective findings on the right-hand side for the same issues. So when you talk about, and they look at physical fatigue, mental fatigue, and a lack of motivation. When you look at physical fatigue and you're looking at something you would get out of a questionnaire or by talking to an individual, they would say something like, I have difficulties performing physical tasks. Whereas if you look at the objective sign of physical fatigue, you would give them a physical task to perform and they wouldn't do as well at it. So you would measure how they couldn't walk on the treadmill as far, say. If you look at mental fatigue and it's a subjective symptom, they would say, I have difficulties concentrating. So you get mentally tired when they're concentrating. Whereas when you measure it objectively, you might give them a computer program where they have to keep doing something over and over again, and they don't do as well in a task that involves cognition. So this is brain fog. When you do that kind of test. And then when you're looking at lack of motivation, when you look at subjective symptoms, when an individual might say, I don't really feel like, or I don't want to do anything. Whereas when you look in an objective finding, you might give someone what's called a hedonic reward. Just means that it's a pleasurable reward. I don't know, getting a bowl of ice cream or something like that, and they're less inclined or less motivated to go and get that, or go out and hang out with friends, and they or something like that. Something that you can measure, essentially, not through a questionnaire. So when I think of central fatigue and PSC, the question I ask myself is, how does inflammation in the liver, so you have a liver way outside of the brain, with or without gut inflammation, and you also get, because of how PSC affects the liver, your bile is not flowing properly, so you get an accumulation of bile-containing stuff. How does that give rise to changes in the brain that give rise to altered behaviors like fatigue? So in the setting of PSC, pathways, so linkages, have to be established, or they might already be established and they have to be activated or started or stimulated in the within the body to generate these signals that then go to the brain. And then those activated signaling pathways within the body have to lead to changes in the brain and change brain function that then cause symptoms, because symptoms have to come from changes in brain function. And the current theory that is most cited to explain how central fatigue might happen by changes in the brain relies on changes in an area of the brain, which I'm going to talk about a bit. The name doesn't really matter. It's just a part of the brain. It happens to be called basal ganglia, which is a number of parts that talk to each other, actually. It's an area of the brain that really plays a very important role in this balance between motivation and reward. And so central fatigue is felt to be inherently an imbalance between motivation and reward. So the problem is sometimes it's easier to measure things like in the bowel or measure things in the blood, but it's very hard to measure things in the brain. And this is why there's not a lot of literature about this, but especially in people, in animal models, they can do it more readily. So how can you measure changes in the brain, either structurally or functionally, in PSC patients? Well, there's really no data on this. However, there is data in people with PBC and people with IBD, which I think we can learn from, because it's going to inform us about changes that might happen in the brain in PSC patients that could give rise to a symptom complex that has some parallels to PBC and IBD. So what I've been doing in my lab for quite a few years now is using something called functional MRI, or fMRI. And really, we're using that to define objective changes. So when I say objective changes, these are something that is measurable, and it's something that's consistent in a group of patients compared to people that don't have the disease. And so when you talk to scientists about objective changes on a functional MRI, they go, "Oh, okay." If someone tells their doctor, "Well, I'm fatigued," often they don't get the same reaction. So I really felt it was important to identify objective changes in the brain, and changes in brain areas that regulate behaviors, especially the ones that regulate motivation and reward and are linked to the development of central fatigue. And so when people think of MRIs, they often think, well, I wrecked my knee, and so I went and got an MRI done. Well, that's looking at structure. And so you can use MRIs to look at structure in the brain, like this picture here. And that's really to look at changes in maybe in a specific brain region. Is it smaller? Is it bigger? Is there a tumor? Has there been a stroke? Those are the kind of things that structural MRI or standard MRI is used for. So what's functional MRI? What does it show? Well, functional MRI actually it uses the same machine and same thing, but it uses the information that comes out of that machine in a different way. And what it does, it looks at changes in the oxygen, how much oxygen is being carried in the blood that goes to the brain, and how that blood flow is flowing within those blood vessels within the brain. And so when a part of the brain is active, it needs oxygen. So it pulls the oxygen out of the blood into that part of the brain. And so because you keep needing that oxygen in the brain, the blood flow has to increase to get more oxygen to that part of the brain. So what functional MRI is doing is is looking at parts of the brain where blood flow increases either at rest or in response to some task, telling us that a part of that brain is active at that time. So it's looking at really activation of brain neurons or nerves. And so you can use it to define neural activity in a brain region, and something's called ALF. I'm not going to talk more about it, just call it ALF. And so that tells us in a given patient group, say, is a part of their brain functioning the same, less with regards to neural activity, or more with regards to neural activity compared to, say, a healthy controls. The other thing that it can do is it can look at something called functional connectivity strength. And what that is if you have a part of the brain that is active at the same time as another part of the brain, and it might be multiple parts of the brain, but if they're active at the same time, and especially if they're active at exactly the same time, then that is felt to be a very strong functional connectivity. That means that when this part of the brain is working, this one's working too, and they always are synchronized. And so the feeling is, to simplify it, is that those two parts of the brains, or three or four or whatever, they are actually part of what's called a neural network. So this is areas of the brain that talk to each other to generate a behavior like fatigue or whatever, or movement or not fatigue, or thinking clearly. And if it's not working, then you're thinking less clearly. And so when I talk about functional connectivity, what fMRI is doing is looking at these connections between brain regions that make up these neural networks. And so the way I think of it is that these are parts of the brain that are talking to each other all the time. They're always talking to each other, and they regulate certain things that we do. So if we're going for a walk, they regulate or we're walking, they regulate what we see and around us. They make it so we don't trip over logs. They pull all of this information and they talk to each other to make sure that we can do all these things normally. And so when you think of things like cognition or brain fog, well, we're processing information, we're trying to remember things, but if it's not working normally, then how that manifests itself in a person is that they're not thinking clearly, they're forgetting things, these kinds of things. Social behavior, these connections regulate how we want to or how we socialize with others. So if they're not working properly, we withdraw from our social activities. So when we did functional MRI in people with this disease, primary biliary cholangitis, so again, it's a bile flow issue, what we found was that there was increased strength of this connectivity or talking between areas of the brain called the basal ganglia, which are here, it doesn't matter what they are, and the limbic system. Okay. And so, obviously I don't think any of you are neuroscientists, but these areas of the brain are very important for certain behaviors. So when you look at the basal ganglia, so over here, they regulate our motor control, but they also are really important for regulating our cognitive functions. So this is processing things in our brain so we think clearly. That's what that means. And also for decision making, so we can make decisions quickly and precisely and about learning. So you can see if this isn't working properly or not connecting properly, how something like brain fog or fatigue could happen. The limbic system is a very primitive part of our brain, which is actually called the emotional brain. So it's critically important for regulating our emotions and our reaction to things in an emotional way. It also manages many different behaviors and it controls motivation. So motivation, reward. It's important for forming our memories. And it influences a part of our nervous system called the autonomic nervous system. And what the autonomic nervous system is the part of our nervous system that if you think of the fight or flight, so if a tiger jumps out of a bush, your autonomic nervous system is full on because you're panicking getting out of there. And so that's part of the stress response. And so the limbic system is very important for regulating that response or this stress response, especially emotional behavioral responses that are crucial for survival. And so stress response is obviously very crucial for survival, because if you just stood and stared at the tiger, you're not going to be around for very long. So what about functional MRI changes that might go along with people that have inflammatory bowel disease? Well, we just published this a couple of years ago. So we took individuals that had inflammatory bowel disease, but they did not have PSC. And what we found that in a similar pattern, but not exactly the same, that PBC patients, so people with this cholestatic liver disease, PBC, and IBD, they had similar enhanced functional connectivity between this limbic system and this basal ganglia. Some of the areas, this is shown on over here, some of the areas are connected differently in IBD than PBC, but the basic concept is here that the two diseases that are, one a liver disease and one a bowel disease, that are associated, that have overlaps with PSC, there is these two systems are hyper-connected. And what that means, we're not sure of, but they control behaviors that, like fatigue, brain fog, emotions like depression, anxiety. Many of these emotions and behaviors are regulated by how those two areas talk. So you could see if there's dysfunction or there's a change in that connectivity from normal, that you could easily see how that could give rise to behaviors like fatigue and brain fog. There's also there's an area of the brain called the hippocampus. And it's a part of the brain that's important for forming new memories, but it's very important for cognition. Because we take in memories, that's really how we form things, like remembering where the keys are when we put them down. You forget where the keys are, but your hippocampus is processing that to say, well, remember that the keys are over there in that dish because you're going to go get them later. And also, in people that have significant depressive disorder, it's well known that the hippocampus changes, and they get dysfunction in a way that they get brain fog, and they can get mood problems like depression. And what we found in patients with IBD is that their hippocampus, if they had mild disease or moderate disease, in moderate disease, their hippocampus, their neural activity, which is this ALF thing, was higher than if they had mild disease. There's also a part of the brain, and I'm not going to make all neuroanatomists. However, I think that some of these areas are important. I'm not going to mention them all, but if you look at this area in the brain, it's called the thalamus. Every sensation that we have, so whether it's inside our body, so feeling like our heart beating, or our intestines moving, or pain in our liver, or things that are outside of us, like touching our skin, like scratching, like seeing things, all of those sensations come through the thalamus, and then they get sent up to this part of the brain, which is called the cortex. And so the thalamus acts as a relay station, but it's also a very important part of the brain that regulates motivation and reward. And so when you look at IBD patients and you look at the CRP, this is called C-reactive protein. It's a marker of inflammation in the body. It's widely used in inflammatory bowel disease, and anyone with inflammation. The higher that level, the more inflammation is felt to be in the body. And if you look at thalamus volume, in people that have inflammatory bowel disease, the higher their CRP, so the more inflammation in their body, the bigger their thalamus volume is. If you look at how their thalamus connects to this part of the basal ganglia, which is called the pallidum, which is a big part of the reward system. So this is how they're talking to each other. You can see that, again, as the inflammation in the body gets higher, those two areas are much more strongly connected. So they're activated at the same time, much more profoundly, as the inflammation in the body gets higher. So this tells us that inflammation in the body is changing structure and function of the brain. So what about change of the thalamus in PBC patient? I'm going to go through this relatively quickly, but you can see in in PBC patients, so again, bile flow problems, that the thalamus is smaller in PBC patients than it is in healthy controls. And thalamic size, so smaller thalamuses, are associated with mental fatigue. in if you just take a normal population. The smaller the thalamocyte, the less well they do in mental fatiguing activities. And this is not the details in this aren't important, but this is just a map of connectivity in PBC patients between the thalamus part and the top part of the brain called the cortex. And what this tells us is that there's that the connectivity is altered in these individuals that have severe fatigue compared to those that have mild to moderate fatigue. So the fatigue itself is associated, or the severity of fatigue, with changes in how that thalamus is talking to the upper parts of the brain. So I think what this information tells us and how it relates to PSC is that PBC patients have changes in this functional connection of neural regions in the brain, including the thalamus and the cerebral cortex, and it's linked to fatigue severity. I can't tell you if PSC patients have that same thing. However, I wouldn't be surprised if they have a similar type of thing, because in multiple sclerosis and in long COVID, similar things have been identified and are associated with fatigue. And if you look at both PBC and IBD patients, they have this increased connectivity or talking between the basal ganglia, so this cognition, movement, motivation part of the brain, and the limbic system, the emotional brain. And so they're talking much more robustly than they are in people that don't have either one of those diseases. And so these areas are very important for motivation and reward. So you can see how they could really drive things like fatigue generation. I'm going to turn now to some treatment approaches for central fatigue in PSC. And obviously, many of these are not necessarily proven, but I want to give you a conceptual approach, I think, at how a way to approach fatigue in PSC, and maybe some things that are worth giving a shot for individuals that might have significant fatigue. These can target the signaling pathway, changes in brain function, but ultimately their goal is to improve fatigue. So a critically important thing for any time someone has fatigue, before attributing it to a disease, make sure that they don't have something else that's easily treatable, or like their thyroid's not working properly. And of course, things like getting good sleep and rest and avoiding tasks that are or limiting tasks that cause more profound fatigue, I think is our reasonable approach. I'm going to break down the treating sort of non-liver cause into all of these different things. But basically, there are many medications that we take that are prescribed over the counter that cause fatigue, like antihistamines would be a classic example. That's a major cause of tiredness or fatigue in individuals, and people during allergy season take these quite regularly. If someone's anemic, fatigue is the most common symptom. Certain electrolyte imbalances commonly are associated with fatigue. And so, high potassium, low potassium, sodium in your blood, blood sugar problems. Obesity, especially if it's associated with sleep apnea, is commonly associated with fatigue. People wake up tired. Other chronic diseases like kidney or lung disease, substance misuse disorders like opioid use, commonly associated with fatigue. Alcohol misuse, commonly associated with fatigue. As I mentioned, thyroid disease and chronic infection. When you look at contributors to fatigue broadly and also in PSC, obesity has many overlapping contributors. So it can generate sleep apnea, and so people often will wear the CPAP machines as a way of not waking up tired in the morning from frequent awakenings and poor sleep quality. Metabolic factors, so diabetes and insulin resistance, commonly associates with obesity, and they're commonly associated with fatigue. And in fact, if you look at diabetes or obesity, fatigue is the most common symptom that people experience. Obviously, poor sleep quality. If you're not sleeping well, you wake up in the morning, you're tired. And what happens also is that people from many different causes can become inactive. And as we become more and more inactive, we become deconditioned. So to do the same activity that we did before, we get more tired. And so it becomes this vicious cycle of not doing activity and becoming more and more deconditioned. There's also, Psychiatric comorbidity is common in society. So things like depression, anxiety, and panic disorder, eating disorder, these are all common, and they're often associated with fatigue. And so it's important if someone has clinical depression and they have fatigue, it's important to treat their depression. But antidepressants broadly are not useful for treating most causes of that are specific for disease-related fatigue, like fatigue in PSC or in PBC. There's also something called somaticization disorder, which is less common, but it's when people feel a psychological distress like PTSD. It can also develop in the form of somatic symptoms, and somatic symptoms can sometimes, which are symptoms that they're experiencing essentially. And which fatigue can be a component of that. So fatigue is commonly seen in people with PTSD. Also chronic stress. So when you have chronic stress, you sleep poorly, but your body's constantly on has activated this stress response. So you're constantly your body physiologically is in a stress mode, and the stress can be social, psychological, or inflammatory stress. But this actually can directly contribute to fatigue. So when I think of approach to fatigue and PSC, this is actually a very nice sort of algorithm that was developed by David Jones and coworkers in the UK. But it's basically to look at fatigue and then look at the symptoms that people describe. So are they describing muscle weakness? Are they describing that they're weak? Or are they describing things like malaise, feeling like their battery is running out? They just can't get up and do things, which is a central fatigue type thing as compared to a muscle weakness type thing. And what screening tests that should you do? Well, I think it's really important to quantify symptoms. In my clinic, I always use it. I just get people to tell me on a scale of 0 to 10 how bad their fatigue is. Or 10 out of 10 they can't get out of bed, and 0 to 10 they can't get out of bed, and 10 out of 10 they can do whatever they want. And that gives me a way of quantifying with a number how they feel, and then I can follow it over time. And also, if it's really bad, then we can spend some time trying to address that and work on things that we might be able to do to improve that. There are scales you can use, but I think those are more for research, whether they're generic or disease specific. And then it's important to look at management approaches, which really look, are they disease specific? So say someone had PSC autoimmune hepatitis overlap. Well, autoimmune hepatitis is treatable in a different way, and it can often, if you treat it, can improve the fatigue significantly. Other things, like I mentioned, these non-disease things, you can treat them, you can control them better or treat them directly, and then people feel better from a fatigue point of view. And then if people are depressed, it's important that they're treated appropriately. And if they have sleep hygiene issues, it's important to address those with sleep hygiene approaches. And so when you look at fatigue, this is called the TRACE approach, which again is a David Jones's thing. It's treat the treatable, ameliorate the amelioratable, which means just fix what you can fix, help people cope, and then empathize. So this is actually for physicians, so that physicians have a framework on how to approach fatigue in patients. So treat the treatable. If they have hypothyroidism, this is completely treatable with a supplement. If they have an autoimmune overlap syndrome, you can treat it. If they have other viruses or metabolic stuff, you can deal with them. With type 2 diabetes, celiac disease, anemia, these are all treatable. If they have a sleep disturbance, then you can work with them to try to fix that. If it's a sleep apnea, you can do things about that. If they, as I mentioned, if they have depression, you can treat that. If they have itch, you can treat that. If they're taking medications that make them tired, you can work with them to try to switch them to something else. It's important to work with individuals. I mean, it's important that ownership of the issue is from a patient point of view, but also recognizing that it is an issue from the physician point of view, and then helping individuals develop a coping strategy. I'll get into more of this later. And of course, as a physician, the most important thing is to empathize with your patients and work with them to try to make them feel better. This is just an outline of PSC-associated itch treatments. There's a whole framework that it's very important that if someone's itching, that it's addressed, and there's a number of therapies that can be offered. I'm not going to go into them today, but it's important that physicians understand that they need to treat the itch, and that often can help the fatigue. But for sure, it'll help their individual's quality of life, because pruritus directly impacts that. So I'm going to talk about some management approaches that can be considered. I'm not advocating any one of these or any of these in particular, but I think these are things that can be considered. I'm breaking them down into these different subgroups, so I'll talk about individually. So first of all, with regards to diet and dietary supplements, I think many people are very interested in how they might be able to change their diet in a way that might make them feel better from a fatigue point of view or other ways too. And I would say that the diet that's probably come to the forefront in this area is the anti-inflammatory diet. And I mean, the data is I mean, the scientific data is not necessarily um, readily available. However, I think it makes sense that there are certain things that you can eat that are more anti-inflammatory. We know inflammation generally causes fatigue. So if you can decrease inflammation broadly in your body by making dietary changes, it may very well impact your fatigue in a positive way, but it's going to be a healthier diet anyways. And this is really kind of the breakdown, which you can, if you want, I mean, you can just look up anti-inflammatory diets. They're everywhere nowadays if you Google it. There's also a lot of interest in this brain gut axis. So, and especially I think in the setting of coexisting IBD is the concept that the bugs that live in our gut, they release things that can go up to our brain and they can change brain function. This has been very well shown in animal models, not so much in people, but there is a little bit of data on that. And it can affect things like depression, anxiety, different behaviors, potentially fatigue. And how people manipulate the microbiome is through things called probiotics and prebiotics. And so there's a lot of interest in trying those. And I think there's a lot of data from animal models where it might be beneficial. I don't see any harm in doing these. And I think that certainly it's worth trying if someone is interested in trying to modulate their microbiome to try to improve their fatigue. What about stimulants? Well, the most widely used stimulant often, obviously is coffee. I mean, using that in a way that doesn't impact your sleep is reasonable. Broadly, coffee is quite beneficial to health. Almost everything that people look at shows that coffee is beneficial, except maybe if you have an arrhythmia or something like that from a heart point of view. Um, and so certainly I commonly recommend coffee. Because I think it also has beneficial impact on the liver disease itself. And then there are a number of stimulants that people try, like amphetamine type stimulants. I don't recommend those. They're addictive and they can be quite problematic, but people do try them when they're desperate. And things like Ritalin or these other medications that they actually alter the brain neurotransmitters that regulate reward and motivation, actually. So things that are like used for ADHD. What about acupuncture? Well, there are not a lot of studies, but there's some very small studies that have looked at this. I thought that this study is bigger and I think relatively well done. And they did acupuncture and chronic fatigue syndrome in people that just had uh, chronic fatigue of unknown cause. And it was a multi-center, it was randomized, but it was non-blinded. That is part of the problem. Many of these are not. It's pretty hard to do it blinded when you're putting needles in people. They usually know you're putting needles in them. But it improved fatigue in this particular study. So if it's something that one is interested in, I don't see any reason why not to give it a try. What about graded exercise programs? It's interesting. I've been talking for many years. I remember one of the first talks I ever gave about fatigue and PBC, which was probably over 20 years ago. I was talking about graded exercise in PBC patients, and I had a delightful woman come up to me afterwards and told me that I was crazy, that the last thing in the world she'd ever want to do is do exercise because she was too exhausted. And so I talked to her about the concept of graded exercise, and then I hadn't seen her for probably almost 18 years. And I was at a PBC meeting, and she came up to me and said, "I just want to say, you don't remember me, I'm sure, but you changed my life. I went home and I was very angry at you for a while, and then I started to do this, and now I've become an advocate for exercise for PBC related fatigue." So I think there is some some positivity about this. I'm going to talk a little about some of the stuff that actually PSC Partners is supporting, I think I'm quite excited about what it can generate. Graded exercise programs mean it's a gradual increase. It's pacing, doing smaller chunks, and taking frequent breaks. It doesn't mean going out and going on the treadmill for 45 minutes and then the next day you can't even get out of bed. It's a matter of if you can walk around the block and do that for a week and then try to walk a block and a half, and then increase that gradually, and then over a prolonged period of time to give your body a chance to keep up with what it's being asked to do. There's a very nice study that just came out very recently in PBC associated fatigue. And the question is, could it work in PSC? And this is a 12-week home-based exercise program. They had 30 PBC patients, and the PBC 40 fatigue score is pretty robust. And you can see this, the red line is the maximum score. The blue line is kind of, where above it, you're moderately fatigued. You can see all of these people are moderately fatigued. And what you can see is that pretty much all of these people, some people went up, but they came down, but almost all of them over that 12-week period had an improvement in their fatigue. Quite as striking. Like this is, that's as high as it goes, right? Down into a range that would be no fatigue or mild fatigue. And they also, when they looked at all the other components of this PBC-40 scale, many of them like cognition, so thinking clearly, the brain fog part, emotions, this is a sleep quality, and this is anxiety and depression, all improved. So I think that exercise regimen, especially graded exercise programs, have an important component. What about cognitive behavioral therapy? Well, cognitive behavioral therapy targets beliefs and behaviors that might perpetuate a symptom or a behavior. And it's well established and effective treatment for depression and anxiety. In fact, it's just as good as antidepressants. It's also been used as an approach to treat fatigue, and actually, in the Cochrane analysis, it was felt to be an effective way in reducing fatigue compared to usual care, and that it's something that should be trialed. And the nice thing about cognitive behavioral therapy is it's available online and through many different, like Noom would be an example of something that's online that's cognitive behavioral therapy for eating disorders. Now, what about combining cognitive behavioral therapy and other things like relaxation, breathing exercise, and movement exercises? This is something that many of you may have heard about because it links into things that PSC Partners is partnering with and very interested in promoting. And this Empower program was actually developed by Punita Tandon here in Alberta, up in Canada. But the concepts are I think are broadly relevant everywhere. This Empower program looks at doing mind-body movement, things like yoga, exercise, starting at very low levels and grading up to higher levels. So this graded physical activity, doing things to help people feel in control, to reduce that stress response that I talked about. So breathing, meditation techniques. And so what they do is it promotes the parasympathetic nervous system, which is the opposite of the autonomic nervous system. So if the autonomic nervous system is what is turned on when we see a tiger, the parasympathetic nervous system is what's turned on when we feel relaxed. So it's the exact opposite, and it helps people often improve their focus because when the parasympathetic system is active, we can start to think about other things in our head that are not the directly things that are stressing us. And then psychosocial support, so whether group sessions, so looking at this is basically cognitive behavioral therapy, and it's directed at fatigue in this particular approach. And this is kind of how they do it. And there's been 825 people randomized, and they use the waitlist people waiting to get into the program as controls. And then they do these Empower program, which is what I just showed you, or Empower with one-on-one weekly check-ins. And they're looking at how these interventions improve outcomes such as fatigue. And there's actually a PSC partners partnered grant called a PCORI grant, which has just been admitted by Donna Evan and Punita Tannen, which looks at these using Empower in PSC to improve a number of things, but fatigue being a core symptom that they're trying to improve, but also things like brain fog and depression, anxiety, sleep. So there's one group that has that Empower, but the other group has this Empower with specific psychologists supporting cognitive behavioral therapy approaches online. What about pharmacological approach? I'm just going to finish up briefly with those because there are really nothing that's specifically recommended for this, but I'm going to talk about some things that may be useful to talk to your doctor about or to consider. There's something called modafinil. It's been around for quite some time. It's actually used for daytime sleepiness in narcolepsy. It's a treatment for narcolepsy, which is when you fall asleep during the day and you just can't stay awake. You fall asleep even if you're driving. And there was an early study which suggested it actually beneficially impacted fatigue in PBC patients, but there was also a study that suggested it might not, and it can make people's stomachs a little bit upset, but it is something that one could consider. Ondansetron is called Zofran. It's actually used as an anti-nauseant for severe nausea. And in fact, it was trialed in chronic fatigue syndrome. It didn't work, but it actually was trialed in hepatitis C, where fatigue is a common symptom, and it was beneficial. It was trialed in PBC. There's a study I was on many years ago, and it didn't seem to have an effect in PBC, but it's a very benign, well-tolerated drug. There's also a drug called bupropion. It's actually it's a very weak antidepressant. It was actually originally released on the market to be or trialed to be an antidepressant, but they were going to abandon it because it didn't seem to work that well. But they saw that people that were taking it stopped smoking more readily, and so actually it's a key drug that's used for smoking cessation. But what it does, it affects how these two neurotransmitters, dopamine and norepinephrine, it blocks them from being taken back up into nerves. So they stay in the nerve, in the place in the nerve which causes activation of the other nerves. It stays there longer. And it's been used in things like multiple sclerosis, cancer, and chronic fatigue syndrome, and also in PBC. I actually use it in some of my patients with PBC, and it does improve fatigue in some patients. So I do give this a trial in people that are severely fatigued. It's actually used in people that have depression, that have residual fatigue. And it works basically by blocking the reuptake of dopamine, which is really important for reward, and norepinephrine, which is an activating thing. So it activates us. And so it stays around in this area and stimulates this nerve. And it's very important for this regulating this motivation reward balance. And then there's also something called SAMI. It's available in Canada. It's not available by prescription in Canada. I don't know what it's in the States. I think it's also the same way. It's a supplement. It also regulates dopamine and norepinephrine, but also serotonin by affecting how they are made or broken down. And it's actually used in depression, especially in individuals that have depression with persistent fatigue, just like that bupropion was. Interesting, it can also inhibit the production of tumor necrosis factor that's made in the liver, and TNF is a common mediator of fatigue in things like IBD, and this anti-TNFs are widely used in IBD. And it's been shown in diseases where the bile doesn't flow properly that it can improve fatigue, and so I've certainly tried that in some patients, and some get improvement, some don't. But again, if it's significant enough, then I'll sometimes give it a try. So to finish off, fatigue is common in PSC, and it significantly impacts quality of life. I don't think there's any doubt about that. It's very poorly understood, but I think we can learn a lot from what we know in PBC and IBD, and I think this will motivate people to study PSC more in the techniques that I've been talking about. I think there's really a need for a PSC-specific quality of life measurement tool, which PSC Partners is supporting that development. I think that'll be available in the near future. I think that treatment approaches for fatigue and PSC need to focus on removing the secondary causes, healthy living, graded exercise programs, psychological supports like mind, body, cognitive behavioral therapies, and possibly pharmacological interventions for people that are severely fatigued and where these other ones don't work. And so so when I talk to patients, they often say, you know, well, my doctor tells me my fatigue's all in my head. Well, what I tell them to say is that, well, your fatigue is in your head, but that's because a disease like PSC and IBD directly change how our brain functions. And so the consequence of that are things like fatigue and brain fog. Thanks very much. This is Banff, very close to where I'm sitting right now, about 45-minute drive. It's a lovely place. If you ever come to Canada, I recommend it highly. Thanks very much for listening. Oop, go back and stop sharing. Okay, we have time for questions now, and so I'm just going to go through them. I'm going to go chronologically here, and I'll read them out, and then I'll do my best to answer them. If someone is newly diagnosed with PSC in its early stages, can they still experience fatigue, or is fatigue typically only concerned in advanced stages of the disease? Actually, fatigue can be experienced at any stage of the disease, and the markers that we typically use to measure disease, like alkaline phosphatase and how high it is and things like that, they don't correlate with fatigue. So the correlation is quite poor between the traditional markers we might use to measure PSC impact on the liver and fatigue. However, if someone has advanced liver disease like cirrhosis, well, then cirrhosis in its own right, no matter what causes it, can lead to fatigue. So obviously having PSC that's advanced to cirrhosis, you really have that impact of both the PSC, so that inflammatory injury, lack of bile flow happening, and also the advanced liver disease. I hope that answered your question. Are stimulants prescribed to treat fatigue? Some places they are. It's a somewhat of a dangerous road because there are dangers associated with stimulants in that they can be quite addictive. That once you start them, they're hard to stop. They're often fall into somewhat of a controlled substance, especially if they're amphetamine type drugs. But obviously, this is something that if you've tried all the other things, then some physicians do prescribe them. I don't prescribe stimulants, but some do, and you could see how they potentially could work. I try other things that change neurotransmission in the brain, like bupropion, over using a stimulant like a Ritalin type drug or an Adderall type drug. Wondering if there is research that shows the impact of people with autoimmune hepatitis PSC overlap on fatigue, especially when there is liver inflammation in the context of autoimmune hepatitis. Well, there's not a lot of specific information about that, but what I can say is that the most common symptom of autoimmune hepatitis in people that don't have PSC is fatigue, and often it's the hallmark symptom. People will come in and say, I feel really tired. I think there's something going on. And it's also a symptom of a flare in their autoimmune hepatitis. So autoimmune hepatitis definitely can cause fatigue in people that have PSC if there's an overlap. And it is something that's treatable in a different way. You use drugs that suppress the immune system. So it is a treatable cause of fatigue that should definitely be addressed in people that have overlap. Okay, do the mental difficulties that come with having a rare and serious disease like PSC potentially have an impact on fatigue? For sure, there's no doubt about that. I think that when people have uh, uh, any kind of chronic illness, especially if it's a chronic illness where people say, well, there's no therapy that changes the course, and so you have all of those concerns and worries. You already have parts of the brain that are turned on that are the stress response, and it naturally, anyone that's thinking about the future and having a family, or how long they're going to live, all of these things are it's just a constant stress. So, and we know that constant stress is or ongoing stress is associated with fatigue. Um, yeah. And so obviously in a rare disease like PSC, it's even harder because you can see these other therapies happening happening out there in liver disease and in more common diseases, but it just seems that the progress is so slow in PSC because it is a rare disease and it's hard to study. And so unfortunately that just adds to the stress. So what happens in the brain when brain fog gets to the point where patients are missing time? They're awake but not actively awake and can't remember the time has passed or coma. Well, so obviously when people's disease gets to a point where they have cirrhosis, they can actually get something called hepatic encephalopathy, which can actually lead to coma. But I'm assuming you're meaning earlier disease when people don't have cirrhosis where that's an issue. Um, I don't think people understand brain fog very well, but what we do understand is that the brain areas that regulate cognition, so brain fog, if it's not working properly, emotions like depression, anxiety, and fatigue are all interconnected, and they're very closely interconnected. So when they're not functioning normally, when they're not talking to each other normally, you could easily see how brain fog could happen. I think the hope is if we start to figure out why that's happening and what the signaling things are that are driving that, if we can fix that, then hopefully the brain fog component will also be fixed. I mean, chronic inflammatory diseases, whether they're PSC or other ones, brain fog is a common symptom. So I think there are some things that we can learn from other diseases that might be tried, that could be potentially tried in PSC. And I actually think that long COVID, it'll be something because it's so common that I think that people are pushing hard in that area because it's not a rare issue. And maybe that will generate things that we can use in people with PSC. Is a graded exercise program okay once the PSC has progressed to compensated cirrhosis and decompensated cirrhosis? Yes. There's very good data actually coming out of Punita Tandon's group that maintaining aerobic fitness, so an ability to do things aerobic. I not mean run a marathon or do 10 minutes, but just maintaining muscle mass. So it can be quite simple exercises to do that, and maintaining aerobic fitness is will make you healthier. You'll live longer, and if you're going for a liver transplant, you'll do better. So these are all really important things. So it's important to maintain, to be active within the context of what you can do, but um, both aerobic fitness, so whatever that might be, it could just be making sure that you walk or whatever you can do, but also the simple things that really help the big muscle groups, like the ones in your shoulders and the ones in your hips. So when you getting up from a chair, just crossing your arms and being able to get up and down from a chair, that is fantastic exercise. Having light weights that you do with your arms to make sure that these shoulder muscles don't atrophy, especially in advanced liver disease. People develop something called sarcopenia, which is a loss of that muscle mass. And when they start to develop sarcopenia, they become frail. And when they become frail, they don't do well. So it's really important to make an effort to try to maintain that. And I think that Punita has shown that very clearly, that people that do better. Is anything understood about fatigue correspondence to outcomes in the plots presented? Depression, losing hope versus fighting it positively. Well, I'm a very firm believer in positive thinking. In fact, people sometimes say I'm pathologically positive, but I believe strongly that people who think positively and have a positive approach to things are going to be more successful at many things they try, like whether it's a graded exercise program, whether it's trying different things on trying to help overcome symptoms and also help them be healthier with their disease. I think that's absolutely critically important. There is good evidence that people that develop depression often don't do as well in disease, and I don't think that's shocking. So I'm a firm believer in positive thinking for sure. Why does fatigue seem to be episodic? I don't know. I think I have all kinds of theories about that. That's a very interesting question. Um, it could be that the inflammatory component is cyclical. In PSC, there's little narrowings in the like beading in the biliary tree, and so uh, you could easily imagine that bile it's not like water. It's a bit more viscous, and it can form little microcrystals in it. And so you could see intermittent plugging, and people can actually get significant plugging from stones and things like that. You could cause intermittent sort of blocking and then releasing and blocking and releasing. I think that could cause intermittent inflammation in the liver because bile is toxic to liver cells. Um, and also when you build up a pressure in the bile tree, people can feel that. That can cause discomfort. And so I think that activates different things in our brain as well. Obviously, if people get cholangitis with PSC, I was trying to find, I couldn't find it. It was an abstract in a meeting that lately I was trying to find it, where people that get an episode of significant cholangitis, they get fatigue with that. And then when the fatigue recovers, it doesn't actually come back to baseline. They actually seem to have a worse baseline. So I think we're learning more about why it's episodic. I also think that people probably go through cycles and how we cope with it in our heads, and so um, we can activate certain pathways in our brains to try to compensate. But after a time, those start to fail, and I think that's where you can start to get more fatigue, more cognitive issues. I think people can regenerate those sometimes by having other things happen that activate different pathways, which overcome those. One might be something, I don't know, something positive that happens in their lives that changes how they perceive things. And every time we have anything that changes how we think, how we perceive, how we behave, it changes our neurotransmitters in our brain. I think that can lead to these episodic ups and downs. Are the correlations of fatigue and genetic SNPs? Uh, oh, that's interesting for COMT and glutathione. I'm not aware if there are, if there aren't. So I can't answer that, but very, very interesting question. That's quite a sophisticated question, actually. Um, when you think about it, everyone deals with things differently, and we know that resiliency is a big part of how we all deal with everything, and we all have different resiliency barometers or whatever. And there's a pretty good evidence that there are genetic drivers of that, and so not I don't think it's a huge leap to think that it would affect many different things that regulate neurotransmission in our brain. How do you determine the tipping point from brain fog to hepatic encephalopathy? Are there any measures available for physicians to use? Well, that's interesting. There's actually there's a group that studies hepatic encephalopathy, which I'm actually a member of. I'm quite interested in that, and I believe that there's a gradation up to a point. There are classical features of hepatic encephalopathy when it's established. One is that people can develop a specific thing where you get them to put their hands out, and they can't hold their hands up, their hands flop like this. That's called liver flap or asterixis. So people who have brain fog do not develop that, but that's a classic finding of hepatic encephalopathy when it's more overt, and overt being more obvious. Um, uh, and then there are things you can do with EEGs and stuff like that, but most people don't do them. Most people just do a clinical assessment, and hepatic encephalopathy is always associated with cirrhosis, pretty much. And so if someone's not cirrhotic, then they're unlikely to have hepatic encephalopathy. Does fatigue affect the MELD score? No, it doesn't. Itch can be a indicator for transplant. It can be used to give bonus MELD scores, but fatigue is not, because interestingly, if you look in PBC patients, fatigue doesn't improve in all the people that get transplants. It improves in about half of them. And so there's different theories behind that, but one of the theories is that if you go on too long with these changes in your brain, it's really hard to actually make them go back to normal. And so, I mean, I think there's a lot of work that needs to be done with that. Is graded exercise therapy something that you need to go to a personal trainer or physiotherapist for, or can it be simply doing it on your own? Definitely simply doing it on your own. In fact, that program in England, they had videos and things that they could watch. Empower is something that you really do on your own. Actually, there's that thing I showed you, that Empower program. You're doing it on your own, but you're getting support that's virtual, right? And so I think it's really important. I mean, graded exercise could just be, I'm just going to go for a walk. Like I'm going to walk around the block. I don't, maybe you only make it halfway around the block, but you know what? You do that for a week or two or three, and then you do a whole block. And so, it's just a matter of doing what you can do in the context of what you can do in your own life. And obviously, some people can go to a personal trainer, but most of us can. So I think doing what you can and taking advantage of any online supports that you can, I think is super helpful and useful. I think, Joanne, did you want to answer part of that question too? No, maybe not. Frequently have to have ERCPs, and they use propofol for general anesthesia plus other meds. Seems to take longer and longer to get back to baseline, sleeping most of the day after. Any research on clearance anesthesia and how to recuperate faster? Well, propofol is a very fast-acting one, and so I mean, the reason why they use it is because people recover quicker. Obviously, as you have more advanced liver disease, it can potentially impact the metabolism of many of these medications, and they last longer. And if people who have early hepatic encephalopathy, these drugs can actually aggravate that. And so I don't know what your liver condition is, but that could be a potential driver of that. Will it help my PSC to fast once a week? I don't think there's any evidence of that. So some people have what's called metabolic dysfunction associated steatotic liver disease, which is a fancy name for fat in their liver with inflammation. And so if there is that happening, then I think anything that's done to remove that fat out is going to actually make the liver disease less likely to be progressive. All right. Because if you have two things, one's fatty liver disease and one is PSC, and they're both driving the liver to get worse, PSC there's no treatment for, fatty liver disease there is. And so those are things that I think that can be addressed, and whether it's through diet, exercise, or the anti-inflammatory diet, Mediterranean diet, these sort of things, or there's many different compounds that are available now that are being used quite widely, like things like Ozempic or whatever, depending on what the drivers are of that fatty liver. Is there anything known about how well the brain recovers from these changes post-transplant? I don't think so, but I know there's a lot of research happening, mainly in animal models, but I think people are very interested in trying to adapt that to humans, because obviously if fatigue is their biggest issue and they go through transplant and their fatigue doesn't get better, well, that's not a great outcome. So, obviously anything we can do to address that is going to improve their quality of life post-transplant. Is there any evidence of fatigue lasting after transplant PSC? I'm not aware of that particular data, but I would not be surprised that they have a similar issues. What dose do you recommend for Sammy? The doses that were looked at in that one systematic review, and ones that have been studied the most, are 800 to 1600 milligrams a day. Some places that they're supplied as 200 milligrams, some as 300 milligram tablets. I usually start at low doses because it's not inexpensive. People that have issues with anxiety should be very careful with SAMI because it can make their anxiety worse. And so I would be very careful if you have issues with significant anxiety taking it. But otherwise, I would typically start at a lower dose. You take it twice a day, and then give it a whirl. I wouldn't take it more than that. I mean, typically 6 to 8 weeks, you should be seeing effect. If you're not seeing effect, I probably wouldn't continue it. I think we're out of time.
Great.
Thanks very much for those questions. They were great.
Yes. Thank you so much. We cannot thank you enough for all the incredible information you shared with us on fatigue and answering all of the questions from the attendees. This is clearly a very important topic for our community. And as we process all that information that you share with us, we will also be posting the webinar on our YouTube site. So as people can go back and watch it again and also share with others that might want to have this information or look more into fatigue with PSC.
My pleasure.
So we do ask that you take your time, go to pscpartners.org. You can type in calendar in the search engine there to find information on our Zoom rooms and our next upcoming webinar in this series, which will be putting your voice into action, PSC Partners Research Initiatives. And that'll take place on April 22nd. And we'll cover a range of research projects, including new aspects of the patient registry and how you can promote research through your participation, our PSC grants, our WIND project, and symptom assessment project. Our popular Zoom rooms are in full swing already this year, and we'll be hosting the next group sessions on March 18th at 6 p.m. Mountain Standard Time. This is for all the groups that we hold Zoom rooms for on the same date. So adults living with PSC or post-transplant, spouses and caregivers, parents of children with PSC and or post-transplant. And then we do have a special teen room. That one does open up at 6:30. And then you do have to register to join the Zoom rooms. And if you have not attended a Zoom room before, you're welcome to join one of these casual sessions to share your experiences, and it also connects you to others in a similar situation. Next slide. So again, we just want to thank you again for attending, all your incredible questions. So thank you very much. Have a great night, and we appreciate you all.
Let's explore to start anew. I just can't wait.